Welcome. This is part 2 of some tutorials that have been put together by the Australian Dementia Network to assist with the interpretation of FDG PET now that there is a Medicare item number for the use of brain FDG PET to assist the diagnosis of Alzheimer's disease. So this is a case-based learning series. I think we have about 10 cases, and let's get started. Keep this handy. So this is something that I showed in the first tutorial. It's the Neurostat 3D SSP demonstration of the patterns of hypometabolism that are characteristic of the various types of dementia. A very handy reporting aid. So print a copy and keep it handy, not only for doing these cases, but for your day-to-day reporting. Case 1, 56-year-old female with breast cancer was treated with surgery and chemoradiotherapy and then tamoxifen. A year later, she had memory lapses. This was of some concern because her mother was diagnosed with Alzheimer's disease at the age of 64. At the age of 59, she sought more medical attention and had a neuropsychology assessment performed after she'd been referred to a memory clinic. The report concluded that memory was entirely unimpaired. There were deficits in executive function, high-level attention, and concentration, so fairly non-specific findings. The conclusion was that findings combined with static impairment since the chemotherapy is not consistent with Alzheimer's disease. However, she had some imaging investigations ordered at the same time. So this was an MRI scan, and here we see selected coronal T1 3D MP RAGE images. These are high-resolution images for anatomy, and this particular T1 sequence provides excellent grey-white discrimination. So here are the first questions. Which of the following is true? Hippocampal atrophy is a reliable feature of early onset Alzheimer's disease. The MRI scan shows hippocampal atrophy. Medial parietal atrophy is only seen in late onset Alzheimer's disease, and parietal atrophy may be present. Give you 30 seconds to think about the questions and answers. I think 20 seconds is long enough. I hope you've got an answer. Here are the answers. So for question 1, hippocampal atrophy is a reliable feature of Alzheimer's disease. Incorrect. Early onset Alzheimer's disease, and this patient classifies as early onset given her age of onset in her late 50s, has atypical MRI and clinical features. So initial diagnosis is a bit complex, often incorrect. Often problems are attributed to psychiatric or psychological disorders, or sometimes frontotemporal dementia if it turns out to be Alzheimer's disease. Part 2, the MRI scan shows hippocampal atrophy. No, the hippocampi appear normal. Now, the best place to look for hippocampal atrophy is in a coronal slice where the mammillary bodies have become into the field of view. So slice back through, and as you go back, stop when you get to the mammillary bodies, these two structures here. Then have a look at the hippocampi. And we've got a bit of amygdala here and hippocampus here, a little bit of amygdala left there, hippocampus here. And what you're judging is the amount of CSF basically surrounding the hippocampus. So when there's hippocampal atrophy, this space widens and the hippocampus gradually shrinks. And you get also in Alzheimer's disease loss of entorhinal cortex and other cortical areas around the hippocampi. In this case, there's a tiny little bit of CSF there, but that's well within normal limits. Part 3, medial parietal atrophy is only seen in late onset OD. No, in fact, it tends to be more the opposite. It may be the only finding on MRI in early onset Alzheimer's disease. And in fact, hippocampal atrophy is rarely seen in early onset Alzheimer's disease. Part 4, parietal atrophy may be present in this case, and that is correct if we look at the last image. And hopefully I'm not hiding it. I'll see if I can move that just to be sure. There may be a bit too much space up here. So there could be early parietal atrophy. So that answer is correct. An FDG PET was done. Here it is. I'll give you some time to have a good look at it. Let's have a look at the questions. Sorry, first, here's the Neurostat 3D SSP display showing the areas of decreased metabolism. Question. The FDG PET shows dementia with Lewy bodies, Alzheimer's disease, frontotemporal lobar degeneration, also just referred to as frontotemporal degeneration much of the time, or chemo brain. I'll go back and give you another look. Is it dementia with Lewy bodies, Alzheimer's disease, FTD, or chemo brain? So we'll go back just to the Neurostat. So you should have an answer. Dementia with Lewy bodies? No, there is no occipital hypometabolism. And dementia with Lewy bodies is more common in males. So that is another clinical factor against it being the diagnosis in this patient. 2, is this Alzheimer's disease? Correct. The posterior cingulate's only mildly reduced in this case, but the parieto-temporal changes are classic. Let's go back and have another look. So as we can see here, bilateral parietal temporal, slightly asymmetric, worse on the left, and we've got precuneus and some posterior cingulate reduction. And there's a very mild amount of frontal reduction with some sparing of sensory motor cortex. Could this be frontotemporal dementia? No, the frontal cortex is intact. Temporal lobe reduction is lateral and posterior, not anterior, like the anterior pole of semantic dementia at FTD. So it's very much an Alzheimer's disease pattern, not a frontotemporal dementia pattern. 4, could this be chemo brain? The answer is no. There are no reliable FDG PET findings for chemo brain. And this condition tends to be somewhat mild. I don't think there's really been any demonstration of significant brain pathology associated with complaints after chemotherapy. And on testing, these people usually just have a mild attentional disorder. Now, the clinician didn't believe the FDG PET. They didn't like the diagnosis because I guess the patient was young, had a child, single parent who had a child still in high school. There was still hoping for another explanation, even though the FDG PET was reported as typical of Alzheimer's disease. So 12 months later, the patient had repeat neuropsychology, which was reported as stable. And it was also stated the FDG PET findings were inconsistent with the neuropsychology. However, the patient had, over these 12 months, developed increasing anxiety and had stopped teaching. The conclusion, however, of the clinician was at this stage, we cannot make a diagnosis of dementia, and in particular, there is no evidence of Alzheimer's disease or any other neurodegenerative disorder. Now, my first talk, I showed you a slide from Berkeley University looking at clinical diagnosis versus FDG PET diagnosis compared to eventual post-mortem. And FDG PET was both more sensitive and more specific for the diagnosis of Alzheimer's disease. So if you get into this sort of situation, put your foot down. Argue with the clinician. If you've got classic findings like this, there really is no doubt that this person has Alzheimer's disease. Anyway, the patient developed significant cognitive and functional decline over the next year or so with a typical rapid forgetting, shocking memory performance. FDG PET was repeated yet again and showed progression of the pattern that we saw initially. An amyloid PET was done as part of a research project with PIB, and this confirmed heavy burden of amyloid plaques throughout the brain. The initial FDG PET was diagnostic in this case. The clinician just didn't like the result and resisted what was the correct diagnosis until it became glaringly obvious. Here's the repeat FDG 2 years later. Now, the pattern is the same. The intensity of hypometabolism has increased somewhat, but you'll notice there hasn't been a huge change over 2 years. And this is the case with FDG PET. There is really little point in doing repeat FDG PET to improve diagnostic clarity if the first one is inconclusive, unless you wait probably 18 months or so. And by that time, the clinical characteristics may have become clearer anyway. So I'm not a big fan of repeating FDG PET to improve diagnosis. Sometimes if you do it a couple of years later, it does reveal what's going on, but certainly you wouldn't repeat FDG PET in under a year under any circumstances. Case history number 2, 61-year-old male with 4 years of worsening ability to name objects. Recent decline in comprehension and arithmetic. Patient was lacking emotion, was showing rigid thinking, and had become disinhibited. Amazingly, the patient was still working at this time. Cognitive examination wasn't bad. Mini mental state score was 26 out of 30. That is down a bit. In a 61-year-old male, you would expect someone to score a 29 or 30. 27 is getting quite concerning, and below 27 is very concerning. The patient actually did well on the 3 out of 3 word memory recall, but was unable to name any animals on further testing. The suspected diagnosis was frontotemporal dementia of the semantic dementia subtype, and AD was considered a less likely possibility. An MRI was ordered. So here's the MRI with the questions. I'll just move myself a little bit. And the questions are, the MRI shows a normal brain, hippocampal atrophy, anterior temporal lobe atrophy, frontal lobe atrophy. So which of these is correct? Could be more than one. I'll give you 30 seconds to have a look at the MRI. Long enough. I hope you've seen the abnormality. It's pretty severe if you are looking in the right place. So what are the answers? Is it normal? No, the brain is definitely not abnormal. Is there hippocampal atrophy? Yes, but it's mild and it's principally on the left side. Is there anterior temporal lobe atrophy? Yes, this is the big findings. It's quite severe and it's worse on the left. If we look here, the anterior temporal lobes, particularly on the left, you can see the CSF spaces, the sulci are markedly widened and the gyri are thinned. So very atrophic. The other side is affected, but to a lesser degree. If you look on the transaxial slices, you can see that here. We've got all this space around the anterior pole of the temporal lobes and widening of the sulci, and a little bit of hippocampal atrophy. Question 4, is there frontal lobe atrophy? A bit hard to tell, it's often quite hard to pick. I wouldn't say with any confidence that there's frontal lobe atrophy, but maybe a little concerned about the left. In the absence of prior severe traumatic brain injury, the MRI is consistent with semantic dementia. This is another TDP-43 disorder, though it's very different to late, which is also a TDP-43 disorder that affects people over the age of 80. Semantic and other forms of FTD tend to have their onset earlier in the 50s and sometimes 60s. Patient was seen by a specialist who looked at the MRI and felt that semantic dementia was likely, but an FDG PET was also ordered. Here's the FDG PET. I'll give you 20 seconds to look at this. I think we've got a Neurostat. Here's the Neurostat. And the questions. The FDG PET is consistent with previous temporal lobe traumatic injury, a left middle fossa arachnoid cyst, semantic dementia, Alzheimer's disease, corticobasal degeneration. I'll give you a few seconds to think about those questions. Here are the answers. Previous temporal lobe traumatic injury. Well, yes, it could be, but the MRI doesn't show any evidence of TBI, traumatic brain injury. The frontal lobes and the anterior part of the temporal lobes are particularly vulnerable to temporal lobe injury. So it's not uncommon in somebody who's had severe TBI to find this sort of appearance in the anterior temporal lobes, but there's usually some significant frontal involvement as well. Could this be a left middle fossa arachnoid cyst? No, again, you would have seen that on the MRI. Also, the hypometabolism is too extensive. It's going back into the middle part of the lateral cortex. We're also seeing bilateral changes here, and the arachnoid cysts are usually unilateral. Is this consistent with semantic dementia? Yes, it is, although it is a little more advanced than some cases, which may be just in the anterior pole. But here, if you look on the Neurostat, it's not only the anterior pole, but is extending back into the lateral temporal cortex. You may also notice on the inferior view, there's some orbitofrontal hypometabolism. This is also a characteristic feature of semantic dementia. Could this be Alzheimer's disease? No, not given the findings we've got here. There's no significant involvement of the parietal cortex, posterior cingulate, precuneus. Could this be corticobasal degeneration? The answer to that is no. This doesn't look anything like that. And in fact, if we see a case later on, you'll get a better idea of what to expect for corticobasal degeneration. I did mention in my earlier talk a simple rule for classification of FDG PET into frontotemporal dementia versus Alzheimer's disease. If you're not sure, if your 3D surface display is showing both frontal brain and posterior brain changes, then a simple approach to make a decision is to imagine the brain is pivoting in the middle of the brain. The pivot point is at the inferior mid part of the brain. And if on the 3D surface display, such as Neurostat, most of the abnormality is anterior, so frontal or anterior temporal lobe, it tips that way, and you make the diagnosis of frontotemporal dementia. If most of the 3D STP display is posterior, it tips that way, and you call it Alzheimer's disease. And in one paper that did this, very simple maneuver, they claimed in autopsy-confirmed cases of frontotemporal dementia that they had 98% specificity. A little hard to believe, but it's a nice little trick to use when you're uncertain about a diagnosis and you want. It's generally when patients are referred, the referral quite often says query FDD, query FTD, query AD. So the clinician wants to know. So you try and avoid giving a report that sounds like the referral could be Alzheimer's disease, could be frontotemporal dementia. So I use this little trick to commit if things look a bit either way. Case 4, highly functioning 74-year-old woman presented with progressive cognitive impairment over just 3 months, associated with myoclonic jerks and seizures. The clinical diagnosis was Creutzfeldt-Jakob disease. But the MRI was normal and the CSF 1433 was negative. And this is pretty unusual. This is what MRI looks like classically in CJD. This is not this patient. You see increased signal on flare and diffusion-weighted imaging in a cortical ribbon, such as we see here. And you see increased intensity in the caudate nucleus and the thalamus, as we can see here. This is this patient's FDG PET scan. I'll give you 20 seconds to look at it. A couple of helpful arrows. This is the 3D SSP Neurostat display showing the typical decreased metabolism in the top set of images, but also it will show you increased metabolism of Z scores relative to healthy controls, and they're shown in the bottom row of images. So with decreased metabolism and increased metabolism in an interesting distribution. Have a good look. You'll notice this down here, bottom row, this is where the striatum is located. You have the caudate nucleus and the putamen. They tend to curve around a bit like this. And this is showing us the medial temporal lobes. What is the diagnosis? Alzheimer's disease, limbic encephalitis, Creutzfeldt-Jakob disease, frontotemporal dementia, or herpes simplex encephalitis. A few seconds to think about that. Well, this is more of a case discussion, but it's got the answers in it. So this FDG PET shows the features of limbic encephalitis with relative hypermetabolism in the striatum and medial temporal lobes. Let's go back and look at that. So the arrows are pointing to this. Note how bright the striatum, that's caudate nucleus and putamen, is compared to the cortex. And also we have hypermetabolism in the medial temporal lobes. A very unusual finding. There are no typical FDG PET findings in Creutzfeldt-Jakob disease. The scan can look like anything. It can look like a stroke, it can look like diffuse hypometabolism, or it could even look normal. In acute herpes simplex encephalitis, there's intense FDG uptake in the entire anterior temporal lobe, not just focal and not bilateral. Post-herpes simplex encephalitis, after the acute period, this area becomes severely hypometabolic and MRI shows destruction of the anterior temporal lobe. An AD-like pattern of hypometabolism is present in this patient, but this resolved with treatment. The patient was given steroids and plasma exchange and improved. And this is an important cautionary note. Acute brain insults, such as delirium, very common in old people in hospital, will cause an abnormal brain FDG PET. FDG PET does reflect what's going on and how the brain's performing. So if you have delirium, it's not surprising your FDG PET is abnormal, and it tends to look like Alzheimer's disease or even DLB. I have been caught by this. So as a rule, do not try to diagnose a neurodegenerative disease with FDG PET when the patient is acutely unwell. Consequently, I try and resist requests for FDG PET in inpatients who have what could be an acute delirium. It's much better to wait 3 months and repeat the scan after the delirium has settled to see what really is going on in the brain. It was noted this patient had a persistent low sodium, and then an autoantibody screen eventually came back and showed the presence of voltage-gated potassium channel antibodies. This is one of the autoimmune encephalitis conditions. The seizures resolved and the cognition returned to normal with corticosteroids and plasma exchange. And the diagnosis was limbic encephalitis due to VGKC autoantibodies. There's been a recent paper describing various patterns of FDG PET in various types of autoimmune encephalitis. So many of them look like the pattern we've just seen. So here, for example, we've got LGI1 and CASPR2. These are actually both subforms of the voltage-gated potassium channel antibodies, slightly different antibodies, but related. So not surprisingly, they're giving the same appearance of increased metabolism in the striatum and in the medial temporal lobes. So, and B, same sort of thing. You can see it better on the slices than you can on this is an SPM display. It's a bit insensitive, really. So clearly not as good as Neurostat or what we use clinically, but there is some hypermetabolism on this. But you can see it visually. It's a bit unilateral in this case. Also in GABA-B, autoimmune, we've again got the medial temporal lobes and prominent striatum. Anti-Hu antibodies, again, prominent medial temporal lobe, prominent striatum. And then we've got a few other things in C, where there's an NMDR, that's glutamate-related autoantibody. There's a posterior reduction that could be mistaken for Alzheimer's disease or dementia with Lewy bodies, because it does appear to be definitely involving the occipital lobe. So watch for that when someone is acutely unwell. D, this is GAD antibodies, and it's showing reductions fairly broadly in the temporal lobes, cerebellum, and midbrain. This last case is Rasmussen's encephalitis. This is a different, totally different condition, really. I don't think it should be in this article. It's a progressive, thought to be due to slow virus infection that starts usually in childhood as a focal abnormality that gradually progresses and eats its way through the brain and is traditionally treated with a hemispherectomy. So a nasty condition to have. Next case, 72-year-old retired professional, 2 years of memory decline, poor concentration, and inappropriate comments. Possible closed head injuries over 30 years ago, but not clear. Hit by a car on one occasion and fell off a roof on another occasion. Testing shown a mini mental state score of 21, clearly abnormal. California Verbal Learning Test, which is a list of words that you have to learn and showing it repeatedly, and then you have to recall as many words as you can after 20 minutes, was minus 2.5 standard deviations, so clearly abnormal. Minus 1.5 standard deviations would be enough to classify you as having mild cognitive impairment. Minus 2.5 is really quite impaired. Boston naming test, so naming pitches was severely down at minus 5.6 standard deviations. And the conclusion from the neuropsychologist was this was consistent with Alzheimer's disease. But the patient was also showing silly childlike demeanour and inappropriate jokes during testing. An MRI was done, and this reported gliosis and atrophy in the anterior temporal lobes, particularly on the right, and severe hippocampal atrophy. There were also enlarged sulci in the medial and orbitofrontal lobes. So this is suggesting that that history of head trauma was indeed significant, and surprising that not more was known about it, given the amount of permanent brain damage it has caused. Our differential diagnosis in this patient should include 1, Alzheimer's disease, 2, frontotemporal dementia, the behavioural subtype, late decompensation post-head injury, or all of the above. The answers are yes, could be Alzheimer's disease, memory is down, but naming is really down, a bit more than we'd expect compared to the memory decline. Frontotemporal dementia, yes, there's some behavioural inappropriateness. The trouble is the patient's older than we'd usually expect for behavioural frontotemporal dementia. They're in their 70s. Late decompensation post-head injury. Well, certainly the patient would have markedly reduced brain or cognitive reserve given the amount of long-standing brain damage. It's questionable whether this could lead to cognitive deterioration in later life as the as normal brain aging occurs. It would certainly make them more prone to showing cognitive impairment with any sort of brain insult, such as very mild Alzheimer's disease. Could it be all of the above? Yes, we really don't have a clear answer at the moment. FDG PET was done. Here's the FDG PET. I'll give you a few seconds to, 20 seconds to look at it. Okay. Here's the Neurostat. Looks a bit similar to an earlier case. Questions? Which one of the following is demonstrated by FDG PET? Frontotemporal dementia, Alzheimer's disease, old head injury, vascular dementia, or mixed dementia, a combination of some of the above. Let's go back and have another look at the Neurostat. Now, remember, we know from MRI that there is anterior temporal lobe damage and possibly some frontal lobe damage as well. So what are the answers? Could this be frontotemporal dementia? No, the anterior temporal and orbitofrontal findings are consistent with the MRI evidence of old traumatic brain injury. Could this be Alzheimer's disease? Yes, although the changes are mild. We'll go back and have another look. You'll notice there is bilateral parietal reduction and posterior cingulate, particularly on the right, and some precuneus. Not a lot, it's pretty mild, but there are some changes there. Could this, or does the FDG show old head injury? Well, yes, the anterior temporal lobe changes and some of that frontal lobe, particularly the orbitofrontal areas, are likely related to the TBI. Is there evidence of vascular dementia? Well, you need MRI for vascular dementia. I don't recommend FDG PET as an investigation for vascular dementia. MRI is a better way to assess the degree of vascular damage in the brain. And so the answer is no, the MRI did not report any vascular disease. So is the answer 5, mixed dementia? Well, yes, there's mixed findings on this. This person most likely has cognitive decline due to old TBI plus Alzheimer's disease. That old TBI has reduced brain reserve, so even though the AD changes are fairly mild, it's enough to tip them into cognitive impairment. Just to be certain, in this case, the patient did have a PIB amyloid scan, and that confirmed the presence of amyloid plaques, further confirming that Alzheimer's disease was indeed present and explained his recent deterioration in cognition. Case 6. 68-year-old engineer with 2 to 3 years of subtle memory decline, but no functional impairment. That means the patient was still able to do all their usual activities, though they may have had to rely more on memory aids and a diary, etc. But they weren't impaired sufficiently to have to stop usual activities. There was a history of depression with pseudo-dementia diagnosed in 2012 that improved with treatment, but memory was never quite normal. In 2015, memory impairment was noted on testing, and the patient was classified as having mild cognitive impairment. And the traditional thing to do when you make that, well, it's not a diagnosis, but when you classify somebody as having MCI, is you tell them to come back in a year's time and we'll see if you've got worse, and you do that until they develop dementia. Then you say, well, you've got dementia now and it's most likely X or Y, usually Alzheimer's disease. So not a very satisfactory position to be in if you have MCI with a 50-50 chance of developing dementia, and you just have to wait and see. In 2016, the mini mental state score was 26. The word list recall was -2.5 standard deviation, so objective evidence of significant memory problem. Other cognitive domains remained intact, so still classified as MCI, and the MRI was normal. An FDG PET was done. Here it is. Now, you'll remember from my first talk, FDG PET reflects the degree of abnormality. So in patients with mild cognitive impairment, you would expect the changes to be fairly mild. So you do have to turn your sensitivity up a little bit, but not too far, because you don't want to be making diagnoses of AD when people don't have it. So have a careful look. Here's the Neurostat. Here are the questions. The FDG PET demonstrates one of the following: early frontotemporal dementia, significant precuneus and posterior cingulate gyrus hypometabolism indicative of Alzheimer's disease, left temporal lobe hypometabolism due to semantic dementia, no significant abnormality, and it excludes Alzheimer's disease. Can you say it excludes Alzheimer's disease? Have a think about these questions. We'll go back and have a look. Well, these are my answers. Is there early frontotemporal dementia? No, there is no significant frontal or anterior temporal hypometabolism. Is there significant precuneus and posterior cingulate gyrus hypometabolism? No, these regions are normal. Let's go back and have a close look. There is a hint of posterior cingulate hypometabolism, but not enough to call it. 3, there is left temporal lobe hypometabolism due to semantic dementia. No, there is some subtle reduction in the left lateral temporal cortex, but not the anterior pole where you see semantic dementia. Let's have a look. So here on this left lateral view, there is very mild reduction in metabolism. On the inferior view, you can see a bit there. But there's some scattered bits all over the place, so you don't want to go overcalling things too much. It is also hinting that the medial temporal lobes might be a little bit down. Let's go back and have another look. And when I look at these medial temporal lobes, I am concerned, particularly here on the left, when you see this sort of little thin ribbon, it usually means there's a bit of temporal lobe atrophy and hypometabolism, although it wasn't reported as such on MRI in this case. So just a few little features. Can we exclude Alzheimer's disease? Well, should the report say no significant abnormality? Well, yes, it should. You don't want to overcall minor findings, and I've been caught doing this. Thought somebody had the early stages of Alzheimer's disease, but they had an amyloid scan and it was negative. So you've got to be a little careful not to overcall minor findings. So I think the correct procedure in this particular case is to say the FDG PET is within normal limits. Does it exclude Alzheimer's disease? No. In mild cognitive impairment, there may be minimal findings, and this scan is not completely normal. There are some subtle findings that I've pointed out in the medial temporal and the lateral left temporal lobe, even perhaps a hint of something going on in the posterior cingulate, but not sufficient to make a definite diagnosis based on the FDG PET scan. So you can't exclude AD and MCI, although you make it less likely. Now, this patient then went on and had an amyloid PET scan. This is one of the FDA-approved traces. They're a bit hard to get hold of in Australia, although you can if the patient is willing to pay for the scan. And this is positive. What you normally see on an amyloid PET, if there's no amyloid present, no amyloid plaques, you see a white matter pattern. In this case, that white matter pattern has been blurred out, and there's activity going all the way to the edge of the brain. And in fact, here in the frontal cortex, back here in the posterior cingulate precuneus area, and the lateral parietal cortex, and in the anterior striatum and the lateral temporal lobes, you can see evidence of amyloid. So this is actually quite a strongly positive amyloid PET scan. So which of these followings is true? Knowing that the amyloid PET scan's positive, the patient has cognitive impairment on memory testing, significant cognitive impairment. Based on this, is this true? The patient has a greater than 70% likelihood of developing dementia due to Alzheimer's disease within 5 years. There is a greater than 90% likelihood that the patient has enough amyloid plaques to meet histopathological criteria for Alzheimer's disease. The amyloid PET scan is strongly positive. The normal FDG PET has no prognostic value. So which of these statements are true? The first one is true. If you have a strongly positive amyloid scan and significant cognitive impairment, particularly in the domain of memory, then the prognosis at 5 years is not good. So mild cognitive impairment with a positive amyloid scan indicates a high likelihood of progressing to dementia within 5 years. Question 2 is true. A positive amyloid scan has over 90% accuracy for the detection of moderate or frequent neuritic plaques at post-mortem. And that is one of the key criteria for a histopathological diagnosis of Alzheimer's disease. 3 is true. As I mentioned, the scan is strongly positive. There's loss of the white matter pattern, typical of a negative scan, and there's clear binding throughout most cortical areas. Statement 4, the FDG PET has no prognostic value, is false. A normal FDG PET in someone with MCI reduces the risk of progressing to dementia in the next 3 years. So it's a slightly reassuring thing, but and perhaps it would have been more reassuring if we hadn't known the amyloid PET report. But in fact, in this case, It does show that a negative FDG PET does not rule out Alzheimer's disease, and with further investigation, if available, you could get a more accurate prognosis. Case 7. 70-year-old female with progressive aphasia. Language deficit is the most prominent feature for the first 2 years, but now the patient's developing some memory impairment. Her mini mental state score is 22. Now, people with progressive language problems often score badly on cognitive testing, but it can be a reflection of language impairment interfering with the testing rather than severe impairment of cognition generally. MMSE of 22, though, is definitely abnormal and consistent with mild dementia. Here is the FDG PET scan. I'll give you 20 seconds to look at it. Now for the Neurostat. Now for the questions. Which one of the 3 major forms of primary progressive aphasia does this patient have? So primary progressive aphasia is a descriptive term for patients who are presenting with a progressive language problem that will eventually lead to complete loss of speech, but it doesn't tell you the underlying etiology. And there are 3 major forms. One is semantic dementia, which is related to TDP43. One is non-fluent or agrammatic, progressive non-fluent aphasia, which is a form of FTD associated usually with tau pathology. And the other is logopenic aphasia, which is associated with Alzheimer's disease. So, which of these 3 forms of primary progressive aphasia does this patient have? The answers. Semantic dementia, no. The hypometabolism is most severe in the lateral temporal cortex, not the anterior temporal pole. Is it non-fluent or progressive non-fluent aphasia? No. The left dorsal frontal lobe is normal. Let's go back and look at that. So primary progressive aphasia typically affects this area on the lateral views and this area on the medial views and the left hemisphere, but that is clearly not the predominant finding on this scan. 3, logopenic aphasia, correct. There is left greater than right temporoparietal hypometabolism, typical of the logopenic aphasia variant of AD. So it looks like AD, except it's worse on the left. But note there is sparing of the posterior cingulate and precuneus, consistent with relative sparing of memory function. If we go back, you'll see there's a little bit of reduction, but not much in the precuneus and nothing going on in the posterior cingulate. It's relatively intact. Now, this is typical of the variant forms or atypical presentations of Alzheimer's disease. Alzheimer's disease is by and far driven by memory decline. But in some cases, the pathology, particularly the tau distribution, the neurodegeneration, affects other areas leading to a language onset, logopenic aphasia, or a visio-construction confusional sort of problem, which is posterior cortical atrophy variant. And even occasionally, you can get the frontal or dysexecutive variant of Alzheimer's disease. So in this case, it's typical logopenic aphasia, memory relatively intact, so we're not seeing much reduction or involvement in the limbic memory circuits, which include the posterior cingulate precuneus cortex. So as I mentioned, there's 3 major forms of primary progressive aphasia. One is Semantic dementia is a form of frontotemporal dementia, and it's due to TDP43. The non-fluent agrammatic, also called progressive non-fluent aphasia, is usually due to tau, but occasionally can be due to TDP43, and logopenic aphasia is due to Alzheimer's disease with beta amyloid plaques and tau-based neurofibrillary tangles. Case 8, a 58-year-old male accountant, progressive difficulty with calculation, writing and speech, and the speech is non-fluent. In other words, hesitant. You can see the patient struggling to find and get out words. It looks like it's a big effort to talk. They have a clumsy right hand, and he reports not being able to put a key in the lock anymore, but on testing, the strength is normal. Memory and personality appear intact. MRI reports parietal atrophy, but no evidence of stroke. This is the FDG PET scan, 20 seconds. The Neurostat. The questions. Asymmetrical hypometabolism of frontal and parietal. The scan shows asymmetrical hypometabolism of frontal and parietal association cortex. The scan shows right striatal hypermetabolism. There is an incidental cerebellar stroke missed by MRI. The scan shows dementia with Lewy bodies. The scan shows hypometabolism of the posterior cingulate and precuneus, and therefore is diagnostic of Alzheimer's disease. Let's just go back and have a look. So, features, yes, in some regards. There is parietal, temporal, and quite marked frontal hypometabolism, sparing sensory motor cortex, involving posterior cingulate and precuneus. It is bilateral, but it is much worse in the left hemisphere. If you look on this superior view, you can see this striking asymmetry. There is contralateral reduction in the cerebellum in the right side, opposite to the side most severely affected. And with a bit of skill, you can see there's some reduction in the left thalamus and the left striatum. We go back to the scans, we'll see that a bit more clearly. The caudate nucleus in particular and striatum here is reduced along with the thalamus on the left compared to the right. So the answers. The scan shows asymmetrical hypometabolism of frontal and parietal association cortex. Yes. The scan shows right striatal hypermetabolism. No, what it's showing is left basal ganglia, that's striatum and thalamus, hypometabolism. The right side is normal. The scan shows an incidental cerebellar stroke. No, it's showing right cerebellar hypometabolism due to crossed cerebellar diascesis or deafferentation. This is loss of stimulating input from the left side of the brain. Remembering that FDG uptake reflects synaptic activity. So if you've got no neuronal input into the cerebellum, all goes quiet and down goes the metabolic activity. Dementia with Lewy bodies? No, the occipital cortex is not involved in this case. And is it diagnostic of Alzheimer's disease? Well, no, there are some atypical features. The gross asymmetry and involvement of the basal ganglia are not typical of AD, nor is crossed cerebellar diascesis. So this should be making us seriously, there are mixed features. This is not a straightforward case, but these features make you pause and think carefully about your diagnosis. So the diagnosis, could it be frontotemporal dementia, dementia with Lewy bodies, corticobasal degeneration, an Alzheimer's disease variant, or progressive supranuclear palsy? Well, it's not frontotemporal dementia, though there are some features common to FDD. There is frontal hypometabolism, but the most severe hypometabolism is in the parietal cortex. Frontotemporal dementia can also involve the striatum, and we do see that. So some features of FTD, but it's not quite right. Dementia with Lewy bodies, no, we've said that's not present. Corticobasal degeneration. This is the most likely diagnosis. The clinical presentation is somewhat typical for this condition. The MRI finding of parietal atrophy without stroke is suggestive. The grossly asymmetric involvement of frontoparietal cortex and basal ganglia is typical of corticobasal degeneration. Now, this is a tauopathy, and so it does have overlap features with behavioural variant of frontotemporal dementia and progressive non-fluent aphasia, which are also often tau-based. So it's not surprising that we're seeing a bit of a mix of features here on the FDG PET. Could this be an Alzheimer's disease variant? Well, possibly. 30% of cases presenting with corticobasal syndrome turn out to have Alzheimer's disease pathology. So this used to be clinically referred to as corticobasal degeneration, but that now is confined to when the diagnosis is confirmed by post-mortem. And clinically, the diagnosis that is now applied is corticobasal syndrome. Now, amyloid PET could certainly sort this out for us, as could measurement of CSF A-beta42 and phospho-tau. So if you've got access to these investigations, you could make a definitive call without post-mortem as to whether this corticobasal syndrome is due to corticobasal degeneration or an atypical presentation of Alzheimer's disease. Could this be progressive supranuclear palsy? The answer is no. PSP usually shows bilateral dorsal frontal hypometabolism and midbrain hypometabolism, not this striking asymmetry and not the striking involvement of parieto-temporal cortex that we've seen in this case. So this is corticobasal ganglionic degeneration. You can say ganglia or ganglionic degeneration. Rare progressive neurodegenerative disease involving the cortex and the basal ganglia. They tend to have Parkinsonism. They have alien hand syndrome, where their hand seems to have a mind of its own and it tends to wander around, sometimes doing inappropriate things. The other hand often has to reach over and grab it and hold it down to stop it doing things. They have apraxia, so difficulty with complex tasks, such as putting a key in a lock, even though the strength of the arm is normal. And they develop aphasia, non-fluent and eventually mute. So again, there's clinical overlap features with frontotemporal dementia, just like with the pathology. So it's not surprising we can get some overlap features on FDG PET as well. The typical finding is asymmetric deficits in posterior frontal and parietal cortex and in the basal ganglia and thalamus, as we've seen in this case. Case 9. 53-year-old female with 18 months of worsening personality change, repetitive behaviours and a marked reduction in speech. Neuropsychology identified language and executive dysfunction that was worse than the level of memory impairment. This is the FDG PET. This is the Neurostat. Here are the questions. What's the diagnosis? Frontotemporal dementia of the semantic subtype, frontotemporal dementia of the behavioural subtype, frontal variant of Alzheimer's disease, schizophrenia, or progressive supranuclear palsy. And here are the answers. No, it's not semantic dementia. We've been through this in previous cases. The anterior temporal lobe is not involved in this patient. Let's go back and look at that. You can see the anterior poles of the temporal lobes are quite normal. And on the slices, the temporal lobes appear normal. Is this behavioural subtype? Yes. There's frontal, anterior striatum, anterior cingulate gyrus, and insular hypometabolism. So you can see that on the Neurostat, frontal, insular, anterior cingulate, and striatal reduction. Back on the slices, you can see the front part of the brain is markedly hypermetabolic compared to the back part of the brain. You can see the caudate nuclei are involved. The anterior parts of the striatum are down. It's a bit hard to pick the anterior cingulate on PET, and that is probably better appreciated on the Neurostat when that is down. Temporal lobes look okay, medial temporal lobes look okay. Posterior cingulate, subtly down, but parietal cortex precuneus certainly intact. And you can see that those sort of subtle posterior changes on Neurostat, but you often get a few AD type changes in people with FTD as well. Could this be schizophrenia? No, not based on the clinical presentation. Obviously, there should be a lifelong history of chronic schizophrenia to have this degree of frontal hypometabolism. Progressive supranuclear palsy, no. As mentioned earlier case, clinical presentation is not that of PSP, and the frontal hypometabolism is too severe for PSP, and the midbrain appears normal. Let's go back. Midbrain will light up around here on the medial views. And if we look, we can follow the thalamus down, midbrain's looking quite normal. This is another example of behavioural variant of FTD. Now, this is an older patient, still diagnostic, but less clear. There are some features suggestive of mild AD, but on balance, the abnormality is predominantly frontal. So if we go along the top row, frontal cortex is down. There's a little bit of parietal and lateral temporal. On the inferior views, the orbitofrontal or inferior frontal regions are particularly involved. Here's the anterior view showing the anterior part of the frontal lobes. Medial view, so inferior and anterior, going back along the anterior cingulate, but there is some posterior stuff as well, and also some medial occipital involvement. So this has got some mixed features. If we take that simple rule and we put our pivot here in the middle of the brain, then this is going to fall forward. The predominant abnormality is anterior, so we go with the diagnosis of frontotemporal dementia. Now, it would be nice to know if this person has some visual impairment, explaining this mild reduction in the medial occipital region. And as I mentioned, some AD type changes are quite common in patients with frontotemporal dementia. And that draws me to a close. Thank you for listening to these tutorials. I hope you found them helpful. And have a good day. Thank you.